Join me in the pledge. Pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Okay. Chuck and Lisa, public comment?
Oh, we just wanted to be here to answer questions because it didn't get answered right last time, so.
Okay. Danielle, hello, how are you?
Good.
Good. We have before us the approval of the consent agenda. Did everybody have a chance to read the minutes? Yes. They look okay. We had some nice thank you letters. I kind of enjoyed that.
To be approved and presented.
Second. Moved and seconded to approve the consent agenda as presented. All those in favor? Aye. Passes. Okay. Boy, we're getting right into it with Ed. You're on deck. Sure, we could do that. Let's go ahead and talk about the ambulance service and what your concerns are.
I guess we just wanted, we didn't feel we really had an opportunity or to comment on what was said at the last board meeting. So we just want to bring you back some information from, I guess, our point of view.
Good.
So Charlie spoke last time about some of the equipment was aging. Everything ages. And this summer they had planned on buying the equipment, but then due to the hospital financial situation, a proposal was given to us to roll over the lease for another year and then reevaluate. At that time when we had that meeting with them to roll over, they are the ones that offered us the $214,000, and that was for
Lisa, who's they?
Charlie and Tyson.
Okay.
So they were at the meeting with the board, and that was for the ambulances, but not the rescue rig and not the equipment. So that was the number that Tyson came up with for the fair market value.
But through a third party?
Through what Tyson had researched, and that's what he felt that was the fair market value. That was the number they gave to us that night.
Okay.
So Tyson last time said that there was 3 ambulances that were scrapped, and that basically they wanted us, we were going to sell you guys those as well. Well, the 3 scrapped ambulances were not even in the plan. So those are FIPS ambulances, so those are ambulances that have never been licensed as ambulances for the hospital.
Are those the ones that are in Adel and Plush?
There's 2 in Plush and there's 1 here in town.
2 in
So-
Plush? Is there one in Adel?
There's
No.
a regular ambulance.
Regular
you know.
ambulance
Oh.
is in town.
And one of those old outfits that we got from Ashland way back.
That's the one that's in town. Or there's one,
Well, no, there's 3591 is still in Adel.
okay.
Yeah.
So that wasn't part of the deal. That wasn't, and we felt that that was misrepresented, that that wasn't what we were going to sell to the hospital. So the agreement that the proposal that we gave you, those FIPS ambulances were not included. Number one, we can't sell them.
And you
They-
can't license them.
And you can't license them, but they have always been in your fleet as rescue rigs. So right now, the 2 rescue rigs in Plush are basically rescue rigs. They are stocked, they are ready to respond, they are not licensed as ambulances. So nothing has changed on that. Since the beginning of that agreement, that has remained the same. So when Mr. Liticote, you asked, why don't they sell them? And Tyson said, he came back and he said, I don't know, I asked him and, he didn't know why we weren't gonna sell them. But those were they weren't in the offer. Basically, when the hospital bought their ambulance, now is 3472. We took the equipment off a FIPS ambulance that was that the hospital could not license. We had it licensed as an ambulance. As a volunteer, we could do that, but as a hospital, again, you knew going into it, you could not license that ambulance. The equipment, it was stripped off that ambulance and put in the new hospital rig that you guys bought. So basically, we gutted that Phipps ambulance. It is sitting empty. It cannot be sold. It can be given back to the government. So,
Oh, because that was the condition of how you got it?
yes. Phipps rigs, you can turn back into the hospital, or back into the government, but you cannot sell them.
Okay.
So our offer that we made to the hospital was for 3 ambulances, 1 rescue rig, all the equipment except for the JAWS extrication equipment that is Nadel, because that's owned by the Warner Valley First Responders. We did basically feel that that was a fair market value. We, it was a hospital that said that they couldn't come up with the $214,000. That's why we did it over the 20 years. We thought that that was, I guess, more of a working relationship. But also, John, you asked if Tyson came back with a counter offer. There was never a counter offer given to us. And he said that we said no to a counter offer. We know of no
So the
counter
3
offer.
ambulances that you were trying to sell, can we license all 3 of those?
They are all 3 licensed right now by you.
Okay.
They're
So
gonna
2
time
of
out.
those are the boxed ambulances that the hospital is talking about putting new chassis under. But right now they're licensed as ambulances. To my knowledge, the hospital has never asked for a variance to be able to run them longer. Yes, they will time out. We were planning 71 was supposed to be replaced this year. Instead of getting another boxed ambulance, the hospital bought more of the smaller, but that was the whole idea, again, from the beginning of the agreement, that we knew that those ambulances were going to basically time out, or you're going to have to put them on a new chassis. So, I guess we just feel like you didn't get the full picture of us trying to work with you, not trying to sell you a bunch of scrap. And, it looks, at least by the paper, people think that we're running with a bunch of scrap equipment right now. That's not fair to you or to us, in my opinion.
And us as volunteers, we have variances. We can run an older ambulance, but the hospital is not allowed to do that.
Well, they can, you can apply for a variance, just, I don't know if you'll get it or not.
Well, I can speak for myself. I think the intent of us was to get a third-party appraisal, to get appraised the vehicles that we can license. And that would be the amount that we'd be willing to pay. So it's not us valuing it, it's not you valuing it, it's the ambulance company that trades in them all the time or whatever, that we get a third-party valuation or get 2 of them or whatever. So that we get a fair value for us and for you.
And
Yeah, we didn't come up with the numbers. The only number we came up with was for the equipment over and above the ambulance price that they offered us.
And a rescue rig that's fully
Yeah.
equipped. So the rescue rig wasn't even though it's on the books, it's leased to the hospital, it wasn't even in the $214,000. Nor was any of the equipment on that rescue rig. So, I agree with you, John, in the fact that I do think that that's exactly what we do, that we go out and we say, hey, if the hospital wants to put a new chassis under the boxes, the large boxes, fine. Get fair market value on those heart monitors. They're $20,000 to $45,000 heart monitors a piece. But when you asked, did you counter offer? No. Has anybody ever come back and said, hey, how are we going to do this? That's what we would like to see. We would like to see, again, that joint agreement, not that we're trying to take you to the cleaners, because I don't think we are.
And then there's a list of the equipment, because that sounds like that's significant.
It's significant.
But even though it's used, they should be able to value it.
Oh, yeah,
I mean,
they can put a value on everything.
Yeah.
But I mean, you just look at the heart monitor and the Stryker gurneys is $90,000. So, I mean, I think you will be surprised because you didn't have to buy any of that equipment to put in your new ambulance.
Well, I guess I'm fine with getting several
third-party
third-party valuations and an equipment list, and we have to fully know what we can and can't license. Because what we wanna buy is stuff we can use.
Right.
And I think that's a fair way to go about it, I think we should proceed down that road.
You aren't gonna
Charlie,
get,
you have comments?
Sure. I think it's unfortunate that the impression that was given in the paper was not exactly accurate. What I brought was the letter that we got from the disaster unit board offering an alternative to the proposal that we had, which was based on the estimate from the third party that we talked about. That was how we came up with that dollar. I'm not certainly capable of estimating value. Tyson asked and got an estimate. In August, I talked with the board about, this was based on the estimate, if you recall, it was about $215,000. Don't remember exactly the number. And I suggested we ought to buy it at the fair market value. I didn't know at any time that there was any interest in even talking about the rigs that are in Adel. That was never part of it, and I never thought that to be the case. In the letter, it said all the equipment. And so we assumed from the letter that the board sent us, Tyson and I, that that's what you include. But no, we're not trying to suggest that you were selling us equipment that we couldn't use. We unquestionably know that those vehicles that can be run as rescue rigs off-road, they can be brought to the road and then the patient put into an ambulance because they can't be licensed for on-road, right?
We could, but
We can.
But then as soon as we changed over to the FEPS agreement, there was probably a way that we could make them go around, but they're old enough, you don't want them.
Well,
But the bottom line is this. Because of the financial situation and the uncertainty that we're facing this year, I recommended to the board, rather than purchase outright all the equipment and give you that 215 plus whatever it was, whatever the fair market value was, that we continue the lease for another year until we have a better idea. I mean, my goodness, you must remember in August, we were looking at the Delta variant and how much impact that's going to have and what is the financial impact for the organization. We talk a lot about how much cash we have. So I felt it was prudent at that time not to imply that your offer was not a good offer, just not an offer that we can accept. And that's all I was saying. And all I brought up at the board meeting when this was talked about is your counter offer. That's all. So I'm sorry if there was any misrepresentation. We sent the same thing in an email saying that there was no intent, and there still was never any intent to malign the group at all, the disaster. It's just a function of we'd like to put that off for another year.
well, but I guess in my opinion, what was not presented to the board is there was not a counter offer. We didn't turn down a counter offer. Basically, you said no, which is fine, but it ended there. So it looks like,
And you're right, we did not try to negotiate.
Right.
Because our intent from the beginning of the agreement that we worked on was that we would get fair market value, and that's what we would pay. I believed in the organization's best interest that we needed to hold on to that money for another year. Your offer of spreading it over 20 years was an alternative. But that wasn't, in our opinion, my opinion, in the organization's best interest. Not that it was a bad offer, it's just not in our best interest.
So when does when we roll over, when does that end?
So
That would end in
August.
August 31st.
So Lisa and Chuck, what if you guys, between now and August, or I guess starting June or July, give us a detailed list of all the equipment, the model, the year?
we have those.
Yeah,
You do, they do,
And
they do.
You
If
have all
your
that.
goal would be to have the two companies, provide value, we'd look at maybe doing that at that time. Is that what you guys would like,
And a complete list of all the equipment, then
that you guys want to sell?
We have we have those equipment lists, there's no question about that. I mean, they're very upfront with it. They provided us, we know what is on the equipment, we're maintaining what's on the vehicles right now. We're providing, if something breaks, we fix it, if something, whatever. But the list of equipment is unquestionable.
Why
They
don't,
provided.
why don't we get valuations next summer and
Well,
We're
and that's-
happy to do that. All we wanted to do was to extend the agreement for another year. I mean, the agreement called for that as an
Right.
option.
yeah,
And that's all we're saying. There was never any other intent. Okay?
I think the 215,000, I mean, how it was represented to us and what Tyson said that he got the quotes for, or the fair market value for, was basically for 3 ambulances. No equipment, no rescue rig. So when you look at 3 vehicles stripped, and then you look at 3 ambulances, a rescue rig fully stocked, I don't think that the $75,000 more is by any means out of line. That's what I'm saying, and basically, the letter back to us was just like, no, that's way overinflated. So, I just think that what our offer included, was not 3 scrapped ambulances. I guess the issue is going to be if 71, the box ambulances are not re-chassied, they are gonna time out for you. So, are we gonna do the $1 a year until we're left with an ambulance that you can't?
but it sounds like your intent is that you'd like us to buy them at the end of your agreement.
Either that or we'll probably we'll probably put into action our ability to basically sell them at fair market value. If not to you guys, to someone else.
And Lisa, is it an all or none thing if we decided we wanted this but not that? Is that part of the negotiations, or is it take it all or nothing?
I don't know the answer to that,
Okay.
because obviously, kind of like having a yard sale, what's left over probably should
But
be
if there
junked
was something
anyway,
that we felt, gee, that we could get that for half price someplace, why would we pay yours
Right.
and just delete that? I guess that's what I'm trying to find out.
And I don't, I can't, I don't know, I don't know what that's gonna be. I think those big, the problem that you're going to have, that a lot of people don't understand, is the smaller ambulances. The reason why we have 2 big box rigs is not because, we have huge people, it's because of the weight. So when you fill one of those with extrication equipment, the smaller ambulances, you basically outrun the chassis braking system and you're illegal. So when you have to run a big box ambulance with all your extrication stuff on it to be legal. So it's not that, we wanted the bigger the best or the show is, it's because of what we have in it. One of the issues that I still contend with today is the weak point of Lake District Hospital's ambulance service is your extrication and your extrication ability. And that's part of being able to offer that. That was part of the agreement that, that you provide that service equal to or better than what we were offering. And so I think you have to be careful when you wanna trade out to everything for smaller rigs. Because part of your deal is you gotta provide extrication.
We're getting down into the weeds a little bit.
Right, I know.
That's okay, that's fine, we need to know the details, but John, would you be willing to work with Charlie and Lisa and get to an agreement?
Yeah, I think what I'm hearing is you'd like to have a target is by the end of this season, so next summer, we'd have this wrapped up, and whether
Right.
you get an appraisal, and you get one company, and we get one company to appraise them, and then we average them, or however we do it, I'd be glad to do that,
That would be great. I'd hate to see you keep your option going until we have nothing.
Yeah.
You know, you can see every year the stuff's gonna appreciate.
It's not like fine wine.
You're right.
I just want everyone to keep in mind that as part of our agreement, our original offer and agreement was that we would lease the equipment for a year. We would maintain it all as we have it. And that at the end of the first year, we would have the option of 1, buy all new equipment, 2, continue the lease, or buy out at fair market value, not us, says getting independent people to do that. All we asked is to extend that for another year, which was part of the agreement. At no time do we always want to have a fair assessment for both the disaster unit as well as for the district.
Yeah.
So I'm sorry if anybody believed that somehow we were not interested in that. The offer of paying over time was a lovely offer. It didn't make sense in August. It may make sense in next summer.
Next year, that's
So,
what I'm talking
No
about.
question about
Present
it.
agreement ends the end of August, so you said?
The one, just finished.
When we extend,
Okay,
Right.
so that's our target, is to have this, and the appraisal's all done at the end of August.
Well, hopefully before then.
Before
I
then,
mean,
yeah.
let's
So that we
face
can,
it, yeah.
so when we get to the end of this period, you guys have a plan knowing what, beforehand, what the value is, do you wanna sell it or do you not, and then.
Did you have a chance to look at the appraisal?
No,
They just came with a number to us.
So the way the appraisals work in this is they being there are several companies that buy and sell ambulances across the country. And they said, for this age, for this amount of miles, this is what it's worth. And they didn't come out and physically evaluate each piece of equipment. And I don't believe they did an assessment of the equipment that's on it. I think they said this is what we would expect. So that's how it was done. It's hard to get an outside company to physically come to Lakeview and do an assessment. And we can't exactly take the vehicles out of the area and have them assessed. So it's a complicated, but that's what is done across the country. This is a fair process.
Well, let's shoot for that, next summer, getting this work to get these appraisals worked up, so we, by the end of the period, we have values that everybody knows. And everybody can plan accordingly.
Yeah.
Aim for spring or early summer.
I agree with that.
Good, okay.
We'll have our part done by then.
Thank you.
Thank you.
You bet. It's good to see you guys.
It's a good.
Okay. Now, Ed, you're up.
It works, thanks to your batteries.
Okay, so this is the financial report for October 2021. This is 4 periods in.
Very close to it. Oh, hold on. Oh, hang on.
All right,
April
so
and May.
patient count, acute 363, an increase over 51 over the previous year. Clinics 1915, a decrease of 351 over the previous year. Other outpatient services 5831, an increase of 616 over the previous year. Overall, for the month of October, we had 8,109 visits, an increase of 316 over the previous year.
Charlie, do you have a feeling for why clinics is down? I mean, it was going up, and in the last 2 months it fell
Some of that, I think, you know what, I don't have a good answer. What I will do is do a little analysis of that, of the kinds of visits. I don't have a good answer right at this moment.
So, next is, gross patient charges. For October was 4.148 million. It's an increase of 159,000 over the last October. You see overall it's trending just slightly under budget. For collections, for October was 2.14, a decrease over last October of 223. So I spent days and days and days going through this with the fine tooth comb and why the big swing from September to October. And we were basically, it came down to two reasons. One is the staffing and the, can we say that, people affected by what was going on outside here. They're out of work for 20 days in the two departments that generate this.
Oh, okay,
Yeah, due to COVID.
okay.
So, and because we're working with, say a team of 8, if we lose 4 of them, it makes a significant difference.
Are you seeing, now November's not up here, we're already into December a little bit, are you seeing a bounce back?
To some degree, yes. Basically, and the other thing is too, is if we try to, and maybe I should do it for the next meeting and show a dashboard where we say, okay, per visit, we're averaging this. And that way we have a good idea. Because the other thing that's not in October is there's no very small charges for the surgeries, very small charges for recovery. Anything, related to that has not, hit the books yet, so to speak. So we went through
Cash collections would normally follow
right.
previous months of charges.
Which is, as you can see, is pretty steady and pretty solid.
So the cash cannot collect it.
Right, correct. And it wasn't collected theoretically because we had half the people we needed to collect that early money.
How are you coming along on filling the business manager position?
Right now, we have our interim person from medical records who's 30-year employee of the hospital as a biller. She's training all the ladies up. We're doing lots of training. We have so far 2 candidates from recruiters, but nobody local or really promising quite yet. The best ones we've found lately are in-house or in the area. Which is, sometimes they're on staff already and we have them doing something that they're not even have a degree in, and so.
Back to the collection, it's
Yes.
down, but that doesn't mean it's lost revenue, it should come,
Yeah,
be showing up next month, right?
yes. No, we didn't write it off, we didn't, it's not past timely, this is all like, for the most part, new stuff. Like if we talk about that AR project,
But if we don't fix it, it'll start affecting our cash.
oh yeah, I mean, Jen, everybody's been a part of it, we all, like, she's credentialing, so we go through, make sure everybody's current, make sure everybody's, no expiration, we're not missing anything. System-wise, we follow it from the minute the doc finishes the notes all the way through to make sure it's not getting hung up anywhere. And I think we talked too with some of the insurances doing funny things with the VA insurances, there's about 4 of them out there.
But if you look at our Cerner graph though, most of those are not going in the right direction.
No, I agree. And some of them are system issues that we probably fix 5 of them a day, truthfully. It's just little silly glitches, I guess. There's just a lot of them. This system's supposed to be total, intuitive, run by itself. We can't screw it up kind of deal. But we managed to do that. But we tried to do these workarounds, unfortunately, so.
Is there a time frame where we lose the option to collect?
Different payers, different timeframes, but worst case scenario, a year. We can always submit though and then appeal later. If we don't have, that's the other thing too, is what we do is, we don't have everything we need, we can release it and send it. And when they reject it because we don't have enough of the information they need, we can resubmit.
Yeah.
So, yeah, we don't wanna leave
Just want to
anything
make
on
sure
the
there's
table.
not a time frame that we are up against.
Yeah, no, it's, I'd say most of the builders and coders are, averaging 50 to 60 hours a week. I mean, we're not slacking at all. It's really got our foot on the gas because we want to prove both the system and ourselves that, we don't need, outside folks to do it. We can do it right here. So.
Well, we're looking at outside folks already helping us with some of it.
Yes, and just for that piece, it's kind of like an insurance thing, when we do have half our team go out and these things roll over 90 days. They're a good fail-safe, essentially. But even them, they had some issues too as well. From September, they collected about 575,000, where in October, they only collected 344.
Right.
So.
How are they doing in November?
November, I think it's somewhere in the 750 range. So it'll swing back and exceed what it was
Because we've
previously.
been looking for like $1 million a month from them,
Yes.
and 300 and 500.
And so I think probably the month of December, we'll definitely see $1 million from them. And I know that for a fact because they've worked 46% of our AR over 90. But they got another tranche of, say, about $2 million that for them is easy to get. Well, we don't have the artificial intelligence, truthfully, to do what they can do with it as fast as they can do it.
Right.
So.
Okay, we look forward to that graph going down the other way.
Absolutely, me as well.
Okay.
Days cash on hand, the goal is 90, we're at 82. Trending in the wrong direction, I think December we'll see it above 90 as well. Both from collections as well as different grants that were awarded.
And this still doesn't include the PPP funds, right?
Correct. It's not in that, this calculation.
Okay.
Anything restricted is out of this.
You say that includes grants?
No, I know we have grants coming down that are depositing in December. Which I know is kind of counteracts what I just said, huh?
Yeah.
Apologize. The monthly net income. The monthly net income for October had a gross revenue of 4.14 million, revenue deductions of 977, less expenses of 3.1, and where you're seeing it on the graph there is that negative 2069. Basically, it's the 3.1 with the $1 million add back of that $773,000 from Eastern Oregon Coordinated Care.
Is that the $900,000?
Yes.
Yeah, that was the one-time shot. That's from Eastern Oregon.
Yes.
That's 900,000.
Well, I didn't get a detailed P&L, I got was a summary,
Okay.
Oh, sorry.
so.
My
I
apologies.
couldn't dig in to see what. It just showed a $900 some thousand add back to the bottom.
And I think where we applied it to was to the clinics, what you'll see in the detail, because as soon as we get out of this meeting, I'll resend it.
But it would be helpful that we get the detail, then we don't have to ask these questions. We can dig into them ourselves.
No, absolutely. I'll get them out to you tonight. Anyway, it resulted in a surplus of 1.1 million for the month of October. So it's trending in the right direction, although I don't take credit for that, so drop the ball on the collections there. Okay, so the next one is the year-to-date. profit and loss statement. Through October, total revenue was 12.4. So our budget was 13.1, so we're off short 780. With these AR projects in November and December, I feel like we can catch that up and get back on track. For the expenses, we were underspent, which is always good at 12.9. So less 479. And then down at the bottom there, the ones that matter, the bottom line is.
So that's the 905 I was talking about, that's all I saw.
Yeah, and so what's in that other non-operating is like these kind of one-offs and, certain things that are not included in cost reports or anything else, so. Just to keep them kind of out of the operating. Net margin, obviously, I'd like to see more consistency truthfully, but for the year, it's going in the right direction. And I'm gonna have to, hopefully our hard work in November will continue that trend. Here's the 6-month trend, and just to point something out too, if you look at the average there of the net income, averaging it across the year, 208. Then this was that one where I tried to normalize things, trying to take off the one-offs, and we came up at 226. So I guess my vision is half full, and our actual results are right in the middle. So that's something we're trying to get more consistent instead of always losing balance. Balance sheet, nothing exciting here really. Total assets of 57 million, total liabilities of 47 million, and fund balance of 9.9. The AR project, this is the facility, the 218. This is all the over 90 right now. In the upcoming months, you'll see different variations of this. And I'll also send out the detailed October monthly statement so you can look at what they're doing. The facility stuff is our stuff. That's stuff that ourselves, so the providers have to furnish back to get them, medical necessity letters, that kind of stuff. That stuff we still have to do. HRG has 2,700 in their inventory. You see 45% of it, and then they've already sent out 40% of the over 90 at 1.9 million has been sent to insurance, and the 44,000 for patient responsibility.
So the ones to insurance are pretty sure to be collected.
Yes. Yeah, and if it's denied or it's sitting in hold because they only like to submit it once, so if it's sitting in a holding pattern, then it's in their inventory, the HRG line. So. All right, that's all I have for that.
Any other questions for?
We focused on building AR.
Yeah. I think you'll see it in the detail too. It's
Well, keep after it.
oh no, I
We'll
love
keep
it.
after you too.
No, you'll see us here till like 7, 8 o'clock trying to chase it down.
Okay, good. Don't work too hard, don't burn out, but collect it.
Which other come first?
Yeah, okay. Next item is the unbudgeted grant purchases. See, we've got a vehicle of some sort.
We did. We sent you a document. It's $57,000 that we purchased a vehicle for public health. So it's part of the granting that we got. And our threshold of $25,000, or is it $20,000? Right. So why did you know about this?
Is that our COVID money?
So we have received a fair amount of money. I think I've talked about this in the past. Just in October, November, we've received around $750,000 that has to be used specifically for COVID mitigation, COVID vaccination. And so when we talk about what does it mean for COVID mitigation, tough one, and there's a lot of definitions and a lot of wrangling to make sure that we're using the monies specifically per the guidelines.
We just bought those COVID testing kits.
An example is buying the testing equipment for $27,000 each one to test for COVID. We got another grant fund that we're gonna use to buy the supplies to do the testing. Right now, we don't actually have enough supplies to test all the patients that we want to. We only test symptomatic. So in some communities, they have lots of testing, and so people can walk in and get tested for COVID. We don't have the capacity to do that. So what we're gonna do with some of that grant money is prepay. Put money into an account and say, we wanna buy the supplies to do the testing for COVID for the next year. Because we've gotta use the money, it's for that purpose. But we can't, the suppliers don't have it. So that's what we're using that for. So we used the $57,000 to buy I think it's is it an expedition? An expedition to be used for the public health department. It will also be able to pull the trailers that we have, because we're getting a trailer for public health, for them to be able to go to different parts of the county. So, don't know if we need your approval to purchase those items. Is that what you requested?
Well, it's an unbudgeted, but it's funded through grants.
That's correct. So
I don't think we need,
you want
I
it,
think it's
we
gonna
would
be,
like your approval to purchase.
I so move that we buy public health a vehicle using the COVID grant.
we approve the purchase, it's already done.
Okay, approve the purchase.
Well, keep in mind that the timeline to actually get the vehicle here is like 3 months.
Oh,
So if you choose that this is not a good expenditure, then we can cancel that contract. Because the lead time is extraordinary. An example of some of the opportunity we have with this same kind of thing, unbudgeted items, doesn't reach the threshold of $20,000, is a modification of the clinic, where we're gonna put in a second door off the front main part of 7th Street. To put in that door, and it's where the old specialty clinic, you may remember where that was. We had made that into a closet. We're gonna convert that back into an entrance for our symptomatic patients, patients that present as though they had COVID. We don't know they do, we don't test them.
So they have a separate waiting area.
A separate entrance. We placed the order on the doors, and it's 20 weeks for when we can get the doors delivered. It'll be next June before we will have gone through the winter. But we don't have any choice.
Back to the public health and the vehicle. You applied for a grant to buy a vehicle, right?
We didn't apply for a grant. These are
The
monies that were
funds
granted.
you had an option to spend out of.
So, as an example, every rural health clinic in the United States received $100,000. So all grants, all rural health clinics, we have 2. The money can only be used for COVID vaccination or COVID mitigation. We also got money for public health, specifically for that purpose. And that's the only thing we can use it for. So for some of the monies for the clinic remodeling, we can do that. We can't buy a building with that money, but we can remodel a building. So there's very clear definitions of what you can do, or can't do. And if we don't spend it, we have to give it back.
So I second the motion, Don.
okay. Then moved and seconded to approve the purchase of the Suburban. All those in favor?
Expedition.
Oh,
Or expedition, sorry. They look the same to me. I mistake.
Big gas guzzling machines. So, all those in favor?
Aye.
Motion is approved as presented. Okay. surplus items for disposal.
So we have, when we remodeled the operating room, we took out 2 of the sterilizers and replaced it with more current equipment. Those 2 sterilizers that really can't be used, they're over 20 years old, and they're sitting in our warehouse. We'd like to deem them, have you deem them surplus. We also replaced, you may recall a couple of years ago, the washing machine in our laundry. We replaced that, and we still have that piece of equipment. We used it for parts, we don't need it anymore. They will be, they're absolutely scrap. We would like to have the 2 sterilizers, the 2 washers on the laundry, both from 1994 and 2002, deemed as surplus.
Do we need to make a motion on that?
We do.
Yes, sir.
So moved.
Okay, we move to put the surplus items as listed for disposal.
I'll second.
Moved and seconded. All those in favor?
Aye.
Okay. Okay. Ed, you're back on. Food Lake Medical Services.
All right. Say 1994, I think that was like just a few years ago. I'm looking at the date there, October 2021. It's like, wow.
Is that really 21, 21, and 22?
Probably should all be 22
Yeah.
It should all be 21.
or 21.
Thank you,
Yeah, thank you guys.
Lisa.
21.
You meant
Yeah.
September of.
You're looking at physical.
I know, it's dragging copy and paste. Okay, revenue was 207 in October, expenses were 350 for Lakeview Gardens, which results in a deficit of 142. And you see that big contract labor 0, and that's not correct. It's just, we didn't have any invoices to pay. I wish, I dream of
It'll be a
it.
double number next month then, probably.
I wish we could have accrued it and put it in there that way, but we didn't have anything to go on, honestly, at that point, when these were drafted. So I apologize for that.
And of course, the other expenses at 50, that's
Yeah, what's
the
that?
ways off.
That's the tax. Is it the bed tax? Yes.
Oh, the thing we have to.
Yeah, it's like 47,000.
Gotcha, okay.
That's what.
So that amounts to about $150,000 a year here. And we get billed quarterly.
On the bed tax,
We get money back for it, but it's still crazy.
So the way the rule works is for a long-term care facility in the state of Oregon, if we provide care to 85% of our patients for that patient days, for that time period, then we don't pay. If 85% of the care that we deliver is to Medicaid recipients, then we don't pay, then we don't have a tax to pay. If we, the reason we pay for that is we do have a couple of patients at any given time that are private pay. And so often our percentage is 82, 81, so we're very close that are.
And it's the right thing for our community.
It's the right thing to do.
Needs it.
That's correct. So it's cost of doing business.
Lake Health Medical Supply. For October, I had revenue of 39,000, expenses were 27,000, which resulted in a surplus of 12,340. And then year to date, Lake Health Medical Supply is at 46,386.
Congratulations, this has really turned around.
Yeah, this is 4 months in a row.
Yeah, to see that consistency,
Yeah.
across the board, it's good.
Yeah, truthfully, this one's gonna go way up because they're being more proactive with,
For years it was negative.
I want you to continue to remember that we made it, when we started the business, we felt it would be reasonably profitable. But we didn't do all the right things. So we hired a consultant to help us. We spent a lot of money to have that consultant help us. And we changed our billing system, we changed our software system, we changed a lot of different things. The kinds of equipment we provide for patients that are on oxygen. We changed a lot of things. And
It's working.
it is working. So you're right, we can expect that we will see continuing this kind of trend.
That's all I have.
Okay.
Alright,
Thank you. Any other questions? Okay. Dr. Foster is not here. Medical staff update?
I don't think we had.
We didn't have any, nope.
We did not approve any changes, so privileges.
There'll be quite a few in January.
Okay, we'll look forward to that. Personnel turnover, you're on.
All right. Well, I know that twice in this since summer, I've mentioned the turnover rates.
Right.
We're a little bit closer to the end of 2021, and I wanted to discuss where we are since the mandate and everything that's happened. So going back 5 years, when we look back 5 years to the 2016-2017 fiscal year, we had 242 employees, and we lost a total of 38, either to voluntary or involuntary termination.
will this also include retirements?
Yes, yes. So the voluntary, involuntary termination could include retirement, it could include somebody just wanting to choose a different career, moving out of Lakeview for whatever reason, or maybe they were actually terminated for cause. So the turnover rate fiscal year 2016 to 2017 was 16%. In 2017 to 2018 fiscal year, we had 266 employees and we lost 27. That was a 10% decline. In 2018 to 2019, we had 270 employees. We lost 48. That was a reduction of 18%. And then 2019 to 2020, getting into the pandemic, that'll be the first 6 months of the pandemic, we had 322 employees and we lost 60. So a 19% turnover rate. And then continuing with the pandemic right through to this point, from 2020 through 2021, we had a total of 295 employees, and so far we've lost 67, so up 7 from last year. So a total of 23%.
I have the understanding we have more employees this year than the previous years. Why the drop?
So we have had quite a bit of turnover and not being able to fill the jobs. We're facing all the things that everybody across the globe are facing. People are fearful of working in the pandemic. They're tired of working in the pandemic. They want a different career, perhaps. When you look at the jobs that we have open, we have quite a few jobs open. It's hard to fill right now. People are going out and they're traveling because they can make more money right now. I kind of liken it to an oil boom. When the oil boom first starts, they've got thousands of guys out there working and they're making money hand over fist, and then in 5 years, then they'll be looking for regular jobs again.
So
we're
we
the
have
next oil boom.
27 fewer employees, but that many more travelers.
Yeah, yes, the travelers are able to leave and go make more money. For example, we've had several staff that have gone and out to travel, and unfortunately they have doubled their wage, but the consequences of that are they're having to live away from their family. That gets tiring. In fact, I ran into somebody not too long ago, over the last 10 days, who said, man, I'm thinking about coming back because it's not so thrilling. The money's great, but I'm tired. I'm tired of living in a hotel, or I'm tired of not having any sort of roots down. So that's what we're at. And when you look at this 23% that we're at right now, we are about 8.5% below what the national average right now is.
Oh, really?
For critical access hospitals, yeah. So we're doing pretty good Could we be doing better? Yes, but we've had a lot of angst over the vaccination mandate, angst over the amount of hours that everybody's having to work to compensate for their partner who's now gone off to travel or gone to pursue another career. So it makes it kind of tough. Do I think we'll recover from this? I do, most definitely. I think once we get to a point where we are more in an endemic stage instead of a pandemic stage, I think it will change the dynamics back again. Right now, this is an employee's market, unfortunately.
Okay, very clear, thank you. Appreciate it.
And I do have a packet if you guys would like to see it. I'll be happy to send one with you.
Okay,
Thank
that'd be good. Do we have any questions? Okay, we're to the nursing report. Tori, how are you doing?
I'm doing great, thank you. So, I have a little handout for you, if I just take one of this down. I work closely with Teresa Squires, and one part of my job is following, our nurse staffing committee, which is a combined, committee of equal parts managers and members of the Oregon Nurses Association, so our staff nurses who are part of that union. And so I follow these measures to make sure we're meeting our goals and to help us figure out where we need to do a little bit better. So this is a good illustration of our staffing situation, I think. And I think overall, it paints a nice picture. But to walk you through it, the first line, mandatory overtime, is not something we have ever had to consider.
Are some hospitals doing that?
Some larger hospitals they'll mandate overtime, like each nurse has to work one extra shift a week or something in that nature. So that's not something that we've had to consider at all, so that's great. Voluntary overtime at the end of a scheduled shift. This is, if a nurse's shift is supposed to end at 6:15 in the evening and they stay whether 2 minutes or 2 hours over, that number is what you're seeing there. So for the last quarter, we had 124 nurses who ended up staying over the end of their shift time. Normally, this is, I would say, less than 30 minutes. And this is voluntary overtime, which usually means they're in the middle of helping deliver a baby or providing some patient care or documenting the care they've given during their shift. So they just stay a little later to finish up and carry over. So there's a nice transition of care to the next shift. So our goal is to be less than 25%. So we're at 9.3, which tells me we've got the resources to let people finish their shift in a timely manner and move on their way. Our staffing committee members released from work to attend meetings. Our meetings are during the workday, and like I said, they're 50% management and 50% staff. So sometimes a committee member will be scheduled to be doing patient care, and most of the time we're able to find coverage for them and release them to come to the meeting. But as you can see, during some of our busier times this year, we've not been able to meet that. And of course, with low numbers, 5 out of 6, or in the quarter prior, it was 3 out of 6 times we were not able to release a member to go to the meeting. So that tells me that those shifts were busy and patient care is the priority, so those members weren't present at the committee meeting. Missed lunch breaks, very few, less than 1%, so people are able to get the reprieve they need during their shift, and we've been able to maintain that. So I think we work real hard with our staffing model to ensure that we have someone to provide a break for them. Our model currently is that we have a shift supervisor or a team lead who's essentially the charge nurse for the shift. And ideally, that person does not take a patient assignment. So she's not necessarily got patients that she's providing direct care for. She's making assignments for the team. She's kind of overseeing the whole unit and how things are going. She's managing the flow from the ER to inpatient or any labor and delivery patients that come along. It's kind of the manager of the shift, really. And so one of the tasks that shift supervisor or team lead does is sit in for people while they go and have their lunch break so that everybody gets the break they need and we don't have to compromise coverage on the floor. And I think that's displayed in the next line, where we are able to maintain minimum staffing of 2 staff members on the unit during lunch breaks at all times. So that's the safest way to care for our patients. Shifts were staffed as per requirement. So this number, there's a few factors that have led it to be this way. Staffing is a challenge, as you know here. However, our definition of staffing met is that we do have that shift supervisor or team leader who is not directly providing patient care. So if we do have that charge nurse and that person is only supervising the ins and outs of the shift, then we've met our staffing goal. If our patient census or our staffing is such that the charge nurse is needed to provide direct care for patients and take a patient assignment, then we have not met our staffing goal. Additionally, if we're short on nurses' aides, on CNAs, that's more work that the nursing staff is required to do. Nurses are responsible for the work that the CNAs do, but they can delegate it. So if we're short CNAs, it adds to the nursing workload. And often that would be the factor that would bring that charge nurse team lead person into the patient care assignment. So I think on that bottom row, what you're seeing is, especially in Q3, was a shortage of CNAs impacted us quite heavily. The good news is we've managed to hire 3 permanent CNAs. They're all doing really well, and that's a huge relief to the nursing workforce.
Are these mostly ones from the classes?
There is one from long-term care and one new to the community. I believe the other one is from the class. We're starting another class in January, so that'll be great.
How many nurses on the day shift?
6 nurses, and that includes the team lead shift supervisor. So 5 caring for patients and 1 in charge.
And how many CNA?
On the day shift, we have 2.
Thank you.
Yeah. So overall, I think what this shows is that while our staff can be stretched at times and we'd like it to be a little bit better, we're managing to make sure that our nursing staff is taken care of. They're getting their breaks, they're not having to stay overly long past their shift, and they're certainly not being asked to do mandatory overtime, which are all things that we're grateful we don't have to worry about, so.
I noticed you guys put some new recognition on the wall over there for all the nurses and their certificates. I think that's great.
Yes, yeah, that's been I think it's been a nice recognition for those nurses that have gotten those certifications. And the nurses here are so diverse and so knowledgeable and strong. They really deserve that.
Good work.
Thank you.
Anything else? Questions?
Thank you.
Okay, thank you very much. Thank you for suffering through the evening with us.
Of course.
The CEO report, Mr. Quake.
So I have a couple things to talk with you about. First off, I want to remind you that December 17 is the hospital Christmas party at the Elks. Hope all of you are planning to attend. The team that's working on it is doing a great job, and it'll be a fun time. So hope you put that on. Also, tomorrow night is the auxiliary holiday fair. The Rotary Club, by the way, is helping to get that organized, but our auxilians are putting on a great show. Please, if you can, tomorrow night and Saturday.
Where is it?
It'll be at a fairgrounds. So please come.
What's the time?
I think it starts 5.
To 8 tomorrow, and I'm not quite sure about Saturday.
Probably like 9 to 12 or something like that. I don't recall exactly. But next thing, I sent out to all of you a report. It's put out by SUN, or STN rather. STN, it's a risk assessment. I think it's really important to understand that we do a lot to try and protect ourselves from bad actors, and hospitals are facing bad actors often. We have 2 examples just within 150 miles of us. Sky Lakes was,
Almost shut down.
pardon me?
It was almost shut down.
It was a horrible event. And last week, a hospital in Burns suffered from a similar kind of event, not quite as drastic, but also very, very different. So we spend a lot of energy. We hire a couple of companies to try and keep us as protected as we can. SDN is one of the companies that we use to help us in that process. And as you look through the assessment, the important part to look at is the executive summary. And when you look at the executive summary, it talks about the kinds of risks that we have. I'm not going to present that because I don't want anyone to know what potential risks we have. But as you read through that report, you can see what an independent company looking at this finds and our level of risk.
We also have some recommendations for us.
They do. And we are implementing all of those recommendations. So we're in that process. We've engaged them to look at us on a regular basis. We've talked about this, I think I provided this report in past years. We use a company our software called Barracuda, which is to try and keep spam and malware from getting in. So keep in mind that whenever we have essentially 2 types of systems. One is the patient care system, and one is that email and all the other files that we have. 2 different ways of accessing this, but we try to protect against all of it. And we spend a lot of energy trying to stay safe. We're never perfect, and this helps us to address that. We also engage a company to send potential emails to people to see if they will fall for it and open it up. And if they do, it says, whoops, this, if had been real, you would have potentially allowed somebody bad, a bad actor, into our system. This was a test. Please note these things. These are indicators of why it's something you shouldn't open up. And so we do that a lot. And it's kind of irritating, but it helps you stay vigilant. And we send it to lots of employees because people make mistakes. We get a lot of emails. So, any questions about this assessment? I think it was pretty helpful.
No, I think it's good with following the recommendation to keep all the data safe.
Okay, good. We were asked by the American Hospital Association to revisit the patient billing guidelines that were brought out in April of 2020. Last year, we talked about this in May or June, I don't recall exactly. But if they're asking that all hospitals once again revisit these guidelines, and that will be published that most of the hospitals in the country adopt these guidelines of ensuring that we do all that we can to help people pay their bills, that we're upfront, we're honest about what we charge, we offer financial assistance wherever possible. You've already agreed to them. I just wanted to remind you that we are going to again state that we abide by these policies. And we do. We do all that we can to ensure that we're living up to that expectation. I've been sending out to you our budget, or excuse me, our grant information. Do you find that helpful? I was amazed to once again read that we have right now, we're managing $1,124,000 in grants. And that's quite a big deal. So we're doing all we can to use that money to benefit the county and our patients that we serve. So, you know, it wasn't that long ago that we didn't, when I first got here, we talked about hiring or contracting with a grants manager or a grant writer. And we spent a fair amount of money, we didn't get a single grant. That happened to be 2009. And if you recall, 2008 was kind of a tough year for a lot of people. So a lot of companies weren't getting grants. We've come a long way. And Christy Albertson and all of our staff really doing great. It's astounding to think about that amount of money that's coming into this community. So I'll send this out to you later. It's just an update on the grant status. Lakeview Gardens has, I think I told you at the last board meeting, how we've been assessed. Our inspectors came in and then they came again. Well, we filed our responses on the assisted living and did it within the timely basis. We haven't heard back. And we still haven't gotten the report from the long-term care assessment. That was supposed to have been done within 10 days. We were to receive it in 10 business days. We haven't seen it. So it's a hurry up and wait kind of environment. That's kind of the way things work.
But we responded in time.
We do. And I can't say that we've had a lot of, they call them tags, things that they said, you know, you need to fix this or you should fix that. One of them as an example, for our, I think it was the assisted living, our fire drills didn't identify the time as clearly as they needed. So we adjusted our form. Important things that we want to take care of. Other things, they are more important. We want to make sure that we're documenting correctly. Other than that, it's been kind of slow. Sorry.
Good. We like slow. Okay, any other questions, observations? Okay, we'll go into executive session then under ORS 192-660, bracket 2, bracket A personnel, bracket C medical staff, bracket E real estate, and bracket H legal. 7-minute break.